Thanks so much for having me and for the introduction. Yes, as the Director of Antimicrobial Stewardship here at Mount Sinai Hospital, just want to add, I work with a team of physician colleagues and infectious disease pharmacists, and we work to optimize antimicrobial use, but also are very involved in vaccines as we roll them out here for the health system. So I'll speak today and give a vaccine update. As a caveat, yes, this is sort of where things stand right now in the fall, heading into the winter of 2024. But as you all know, this landscape evolves all the time. It's a sort of rapidly moving target. And so, it's important to stay on top of it, but things will likely change certainly by next fall. So wanted to focus today on what we encounter most in the fall and winter and what we're hoping to keep our patients up to date on vaccinations for those infections. So we'll review some of the epidemiology and I'll give some updates on the recommendations for RSV. In particular, RSV has changed a lot in the past year and a half or so. We'll talk about the currently available vaccine options. There are three, and the newest recommendations on who is eligible for those. COVID-19, I'll give an update on where we are fall 24 to 25 with the vaccine formulation that's available and the recommendations. Pneumococcal infection, so actually very timely. There is a new addition to the pneumococcal vaccine group, which is the 21-valent pneumococcal conjugate vaccine, and we actually went live in the health system this week on Wednesday with that one. And then seasonal influenza, we have sort of the least new information about flu, but a couple of small updates that I'll provide. So I thought I'd frame this with a case just to contextualize and keep it sort of relevant and interesting. The patient who presents is a 66-year-old man. He's coming in for just routine care, has a history of COPD, diabetes on oral meds, and hypertension. And in terms of his vaccine history, he received the initial COVID-19 vaccine series, but has declined further doses. He received the flu vaccine last fall, and he's never been vaccinated against RSV or pneumococcal infection. And he's wondering what vaccines he should get this fall. Just a plug for reconciling vaccines. I'm sure most of you do that routinely and know how to do that, but it is important to sort of hit that button when you see someone, make sure that you're reviewing what's in the vaccine registry and pulling it in. When patients get vaccinated at pharmacies, often that information is there and it helps to just pull it into the medical record. So we'll start with RSV. Again, I think we've got sort of the most information and new recommendations for RSV. So to provide some background, RSV, really does impact older adults quite significantly. Most of the more severe disease is in older adults and in young infants. So we see, between 60 to 160,000 hospitalizations a year from RSV in older adults, and unfortunately 6 to 10,000 estimated deaths per year. And we know that certain medical conditions place patients at higher risk for RSV-associated hospitalization, and that's really sort of chronic lung and heart disease, things like frailty, advanced age, and immunocompromise. And then we're not going to focus on infants here, but it's just worth knowing that really this is a very important and significant cause of lower respiratory tract illness and death in young infants, and this has led to some important developments in protection for them as well. So as of last season, 2023 to 24 was the first season that we had RSV vaccine available, and it was recommended for adults 60 and older, but it was recommended as a shared decision-making between the provider and the patient for that broad age group. And that, we'll talk about, but is a sort of complicated type of recommendation that sort of leaves the provider in a bit of a bind, trying to figure out how strongly to recommend it for each individual patient and weigh the risks and the benefits kind of themselves. This year in June, the CDC did further clarify that recommendation, and they recommended that all adults over 75 get an RSV vaccine, and that adults 60 to 74 who are at increased risk for RSV get an RSV vaccine. And so this was a move sort of away from the shared decision-making ambiguity towards a clearer message, which can help with implementation. At the same time, we have additional recommendations I mentioned to protect infants. So one of the three vaccine options for RSV, which is Pfizer's Abrysvo, is the only one approved for pregnant people, and that's recommended for pregnant patients between 32 and 36 weeks of pregnancy. That is one option. Or now available after birth is a monoclonal antibody that's given to baby called nirsevimab, which is another way to protect against RSV. So that's babies. And for adults, the recommendation is really just a single dose of any of the approved RSV vaccines. There's no preference put out by the CDC among them. And it is not currently an annual vaccine recommendation, but as of now, a one-time dose. I think we all find ourselves now having to speak to patients a bit more about what RSV is, because patients are hearing about it and wondering, what is that? They're more familiar with flu. Obviously, we're all familiar with COVID. Um, so adults with RSV usually have a mild infection, can have no symptoms at all, but if they do, they're often those of a typical upper respiratory tract infection that will resolve on its own. Where we see severe disease and exacerbations of patients' underlying comorbidities, again, is really predominantly in older patients, in addition to the very young. And this is kind of an exhaustive list of conditions that can increase the risk for severe disease. I think most of this is fairly intuitive, but having chronic comorbidities that involve the heart and the lung, having a neurologic condition that leads to impaired airway clearance, severe obesity, immunocompromise, and then a sort of other bucket, which includes things like frailty, are all conditions that we think about and that place patients at higher risk for severe disease. In terms of the seasonality of RSV, it's actually fairly interesting. There was a big impact of COVID-19. So typically we think of RSV as kind of peaking in the winter months. We didn't see as much of it in the COVID years at the peak of the pandemic with COVID precautions. And then when RSV sort of came back, this black line is 22 to 23, it came back and was an atypically early season. But most recently in 23 to 24, we're sort of back to the more predictable winter wave. So this is showing you flu, COVID, and RSV in the last season, 23 to 24, and RSV is the orange line and sort of peaking in January. But really the season we think of as, October to early winter, late spring. And so what's available now is protection against RSV. So there are 3 currently available RSV vaccines. As I mentioned, the CDC does not make a recommendation preferentially for one over the other. And one important thing to note about RSV vaccine is that it's covered under Medicare Part D, which means that under pharmacy benefit given at the pharmacy for most patients with Medicare, who are, we're talking for the most part about older patients. So that means that for the most part, this is not something we're giving in the office a ton. We're majority of our patients we're sending to the pharmacy where they're going to get a vaccine that's available there. So the options again are Arexvy, which is made by GlaxoSmithKline, is an adjuvanted vaccine against RSV prefusion glycoprotein, sometimes abbreviated as pre-F. Abrysvo, which is Pfizer's vaccine, again, RSV pre-F targeting. And I mentioned this is the one of the 3, which is important, that can be given to pregnant patients. And then the newest addition approved this year in 2024 was a Moderna vaccine, Mrezvia, which is an mRNA vaccine, which is now available. So I wanted to not, get into too much of the weeds with this, but talk a little bit about the initial trials, which is the information that we sort of had available last year in the first season that these vaccines were approved. And I think it's important just to understand how the recommendations were made. So the initial vaccine trials were done for the Arexvy, GSK vaccine, and Abrysvo Pfizer vaccine. And this is just showing you that what they demonstrated in the initial trials was efficacy against lower respiratory tract disease. The overall event numbers were fairly low. Again, these were seasons that were impacted by COVID and COVID precautions. And they were underpowered to demonstrate efficacy against hospitalization or death. They also had sort of relatively low numbers of older patients, those over 75. But what they did demonstrate was this efficacy about 83% against lower respiratory tract disease with Arexvy. And they showed that seemed to be, with some preliminary data, somewhat durable into the second season. Abrysvo, fairly similar, demonstrated efficacy in the 86% range against lower respiratory tract disease with 3 or more signs or symptoms, underpowered to demonstrate efficacy against hospitalizations or death, and again, some durable efficacy into a second season with just 1 dose. One important note from those trials was that they did see a signal related to Guillain-Barré. So it did look like there was what they call, there were cases of inflammatory neurologic events, both in the GSK and the Pfizer trials. And this led to an interesting, of course, decision to sort of carefully monitor with ongoing surveillance for safety events for these inflammatory neurologic events moving forward. But was part of the reason that I think the original recommendation was shared decision making and sort of a weighing of the risks and the benefits depending on the patient's profile, age, comorbidities, et cetera. So just to summarize that, the original trials, so, they did demonstrate efficacy in preventing symptomatic illness, but they were not powered to show efficacy against in older adults because they just didn't have the numbers there over 75, and they couldn't estimate efficacy against hospitalization. The event numbers were overall fairly low because this was during seasons that were impacted by COVID. There were patients with compromised immune systems were actually excluded, which is another limitation. And there was this signal for inflammatory neurologic events that was noticed. So luckily, moving forward and now available in 2024, what led to some of the shift in recommendations is the accumulation of post-licensure data. And the CDC did review additional observational studies of vaccine efficacy for the available vaccines, and there was efficacy against RSV-associated hospitalization in adults over 60 that looked to be in the 75 to 82% range, similar across the products. And luckily, there were more patients who were over 75, more patients with immunocompromise that got vaccinated that they were able to look at. They do continue to look at the safety data. And the sort of final conclusion is not final, is still unclear whether there's conclusive evidence of elevated risk of Guillain-Barré, but it cannot be ruled out. And so that remains a sort of ongoing question. There was also a signal for the GSK or XV vaccine in terms of ITP, but on further review, that did not turn out to be a very large number, and they have ongoing surveillance for that. Ultimately, they concluded that the benefits really do exceed the risks, particularly in the highest risk patients. So if you just take a look sort of at their sort of estimates, we expect the highest number of hospitalizations in our older group over 75, and the anticipated benefit is greatest in that group in terms of potential hospitalizations prevented, with a relatively small number. Probably, they estimate less than 10 per million of Guillain-Barré attributed to the vaccine. And then the newest vaccine on the block that I mentioned, I just wanted to touch briefly on, was the Moderna vaccine, the mRESVIA, which was released this year, approved this year. Again, this is an mRNA vaccine against RSV. There was a randomized placebo-controlled trial, large in immunocompetent patients over 60 who got a single dose of this RSV vaccine. And again, they demonstrated efficacy against lower respiratory tract disease from RSV in the initial period of about 81%. This protection, similar to the other trials we looked at, did seem somewhat durable at 18 months out, although at about, wanes to about 50%. Again, not powered to really assess efficacy against hospitalizations, though they did show that RSV-associated shortness of breath was impacted, which they thought was a sort of marker for more severe disease. And there was a low rate of adverse events and actually no safety concern with Guillain-Barré in the mRESVIA study. And data from the real world does accumulate. So I mentioned that the CDC has been reviewing studies of real world efficacy. This was one of them published in JAMA earlier this year, which was a case control study looking at adults over 60 who were hospitalized with respiratory illness. And they looked at cases of RSV versus controls who were negative for RSV, COVID, or flu, and looked at those who were vaccinated versus those who were not, and found the efficacy of the vaccine against hospitalization to be in the sort of 75% range. So that's sort of where we stand in terms of what we know about RSV up till now. And I think there are some ongoing questions and some ongoing obstacles, but the vaccine is available. I think we're all counseling patients, especially our high-risk patients, about getting it. One remaining question is about the role for repeat vaccination. So as I mentioned, the current recommendation is a single dose, but the need for additional doses for coverage beyond 2 seasons is being evaluated. I mentioned the coverage issue with Medicare Part D. I do think that vaccine, access to vaccine is a huge element of vaccine uptake. And so for me, this has been, a bit more challenging to not be able to give it on site to most patients. There's ongoing surveillance for safety events, which I think we'll be looking out for to understand better that issue around Guillain-Barré. And then there are some studies that have demonstrated efficacy in a slightly younger age group, but those 50 to 59 with increased risk for severe disease. And the FDA did approve GSK's Arexvy vaccine for this group, but the ACIP has not made a recommendation around it. I think we'll be waiting to see about that. I can think of a couple of my own patients who have very significant pulmonary disease in their 50s for whom I would actually like to, to see what recommendation is made. Okay, so I want to move forward and talk about pneumococcal infection. As I think most of us know, pneumococcal infection is caused by the bacteria Streptococcus pneumoniae, or pneumococcus. It's a common bacterial cause of respiratory tract infections like pneumonia, but also more severe invasive disease like bacteremia and meningitis. And unfortunately, the incidence of invasive pneumococcal disease is associated with age. So we're talking about older adults, and we know that it can really be unfortunately associated with significant morbidity and mortality when older adults get pneumococcal pneumonia, or particularly bacteremia or meningitis. So the newest vaccine on the block here is the pneumococcal 21 valent conjugate vaccine. I think the landscape of pneumococcal vaccination has gotten very confusing over the past few years. We had the addition of PCV13, but then followed by more recently 15, 20, and I think people have gotten a little lost in what they're supposed to do at this point. So hopefully this makes things a little bit simpler. The bottom line is a lot of people can just get a dose of 21. 21 was approved this year in June and covers 8 additional serotypes. So I think one important message is that it's not the difference between 20 and 21 is not one serotype. Actually, it's broader vaccine coverage. Initially, when the recommendations were made earlier this year, the recommendations were still for adults 65 and older, and then adults 19 to 64 with certain risk conditions. But actually, another important update is that in October, the CDC just lowered the age criteria for pneumococcal vaccination and said all adults 50 and over now should get a dose. So I think there's a lot of folks who probably haven't gotten one yet who are eligible, or 19 to 49 with risk conditions. Again, this is, a big list of everyone who's at risk, and, we don't have to go through it all. You can certainly have it for your reference, but mostly as expected, patients with chronic comorbidities, immunocompromised, and then also a couple of factors that place patients at increased risk for meningitis, like CSF leak. This is really showing, I think, in a clear way, the difference between some of the prior formulations and 21. Up until now, most recently, the recommendation was for a PCV 20 alone, or you could do 15 in series with Pneumovax 23. I think what we saw was that almost everyone was just doing 20 alone because giving one dose of one vaccine was much more straightforward. So now moving forward, those patients would get a 21 instead. And important to show that, again, I mentioned, but PCV 21 is actually covering 8 new serotypes, but there is one hole, which is serotype 4. Serotype 4 is most relevant in the Western US, so a little bit less here locally, but is associated with some risks like alcohol use disorder, substance use, tobacco use, homelessness, and so in some areas more of a concern. And again, I mentioned that the coverage is broader, but really I think you can just see this visually. 19 to 64-year-olds, this is showing you that the PCV 20 coverage was about 58% of the serotypes that caused invasive disease, whereas with 21, we get 81% coverage. And with adults over 65, coverage with PCV 20 was 54%, and now we get 85% coverage of the serotypes that cause invasive disease. So nothing is 100%, but certainly the PCV 21 is providing broader coverage than what we had before. So I think the advantage is, just to summarize, broader coverage against more strains. There are a couple of limitations. So again, I mentioned not covering serotype 4. And of course, more limited long-term data since it's a newer vaccine, but we did add it to our formulary and actually went live this week on Wednesday. So you'll notice if you're using the pneumococcal vaccine order sets that you have the choice of 20 or 21 only because we still have stock of 20. And once we exhaust our supplies of 20, we will move over to 21 and adjust the order sets really just to include 21. Again, I mentioned, but I know this is confusing, particularly as so much has changed in a short period of time with pneumococcal vaccination, and also because some patients have a history. They've gotten a dose of 23, maybe they've gotten both 23 and PCV13. And so the CDC does have a very handy kind of timing diagram here to help guide you. And they also have an app, which is called Pneumovax Advisor. And I'd recommend just having the app because this way, as they update, and I think 21 won't be the last one we see, you can quickly go to the app and sort of see what the latest recommendations are about what to give a patient. Okay. So going to move into COVID-19. I think people feel fatigued of COVID and feel like we've talked about COVID now. We're coming on 5 years in March of COVID-19. But the good news is, of course, we've made tremendous progress. And this is just sort of important to look at the deaths by week in the US. The peak in terms of deaths was in January of 21, where there were something like 25,000 deaths per week. And we're now here, at the end of November, where there's data showing about 300 deaths per week. So tremendous progress, but still deaths from COVID, deaths and hospitalizations. So, our job is to figure out how best to prevent the most severe disease. In terms of seasonality for COVID, I think what differentiates COVID a bit from some of what we've been talking about with RSV and what we'll talk about with flu, that the seasonality with COVID, as we've learned, is not quite as straightforward. So the large red bar here is all ages, and these are emergency room visits. And as you can see, unfortunately, it's not one wave, but it's really two. With a wave in the winter and the wave in the summer this year, this past year, really almost was as high. And so that is part of the challenge with vaccination against COVID is that we know that there does seem to be this fairly sizable summer wave. So that brings us to what the recommendations are as of now. So in June, the ACIP recommended, again, similar to last year, universal vaccination for all persons 6 months and older. And in August, they approved the 2 latest vaccines from Moderna and Pfizer for 24 to 25 in people over 12. This is a monovalent vaccine now targeting Omicron, JN1 lineage strains. You can sort of get really in the weeds with all of the various strains, but basically the strains that have evolved from Omicron JN1. And then the vaccine is authorized for use under an EUA, which is an emergency use authorization for children 6 months to 11 years. And the Novavax vaccine, which most folks probably know is not an mRNA vaccine, so another type of protein subunit vaccine, is authorized for use as well for people over 12. So several options, and they don't make a preferential recommendation of one over the other. Why get a COVID-19 vaccine? So I think we all probably find ourselves in these conversations now. And I think this has been a subject of some debate. But there are a few important points that I emphasize in conversations with patients in particular. So, SARS-CoV-2 continues to evolve. So talk about with the flu, and I think people have a fair understanding of that. There's evolution from year to year, and we know that the strains circulating most recently are these Omicron JN1 lineage strains. And so we want a vaccine that matches what's around. I think people often say, oh, I've gotten 4, I've gotten 5, I've gotten 6. We say, well, we're not counting vaccines anymore, just like we don't count the number of flu vaccines you've gotten in your life. We say this is the seasonal vaccine. It's not actually really a booster anymore. It's this season's vaccine. And we know that the effectiveness of COVID vaccine does wane. So even throughout a season, but is another reason to stay up to date. And unfortunately, though we've made tremendous progress, as we saw, there are still thousands of hospitalizations and hundreds of deaths in the US each week from COVID. And particularly hardest hit are older adults. The highest risk group is those over 75. And then following that are actually very young infants and adults in the 65 to 74 age group. In 2023, there were over 40,000 COVID-associated deaths in people over 65. So still an impact and considered at this point, vaccine preventable morbidity and mortality. Why did they make the recommendation universal? I think the idea is that even though those in the oldest age group are hardest hit, there is vaccine preventable morbidity and mortality in every age group. We have tremendous efficacy and safety data at this point, just sort of from the real world, at least, safety-wise. Over 5 billion people have been vaccinated with COVID-19 vaccines over the past, several years. And having a message that's universal, a recommendation that's for all age groups, does help with access, helps make the message clear, and the idea is to have the vaccine as accessible to as many people as possible. This is an important note, though, about the vaccine is this waning over time. And I think this gets into, impacts the recommendations, particularly for older people. So this is data from the CDC, the ACIP, their vaccine group, looking at COVID vaccine efficacy for both hospitalization and critical illness over time. And the gray is the original vaccine. This dark red is last season, and showing you, fairly strong vaccine efficacy against critical illness and hospitalization in the early months after vaccine. But that does drop over several months. And when you get to the 6-month or so point out, it really has decreased quite a bit. So this informs the recommendations around doses and timing. So I would say heading into the fall, the simple message for most patients ages 5 and up was get a dose this fall. And a single dose is recommended for almost everybody, with a couple of caveats. If you have never been vaccinated and got a Novavax, for example, as your initial series, that is 2 doses. But most patients are getting a dose in the fall. Then in October, the CDC clarified the recommendations around what people have called the spring booster, and said a bit more clearly, we recommend a second dose for people 65 and older 6 months later. So this would be, for most people, sometime in the spring. And really, this is based on the fact that they acknowledge that the risk for severe disease is so much higher in older adults, and that protection really does wane over time. There's not a ton of data, unfortunately, yet on patients who've gotten 2 doses. The numbers have been relatively low. They did present some of this, and there's a suggestion that maybe there's about 20% additional protection against hospitalization for older adults, but that data is limited by the number of patients who've gotten the second dose. Immunocompromised patients are similar. So the recommendation is to get a dose this fall. For immunocompromised patients who've never been vaccinated, that's a multi-dose series, but I think those are pretty few and far between at this point. And then those patients should be offered a second dose 6 months later. And again, this is because we've seen that efficacy in immunocompromised patients is lower, and does wane quite significantly by the 4 to 6 month point. Another frequently asked question is about when people have had COVID infection and what to do about their next vaccine dose. The CDC does say that, for the most part, you can probably delay for about 3 months, but consider some factors in that decision: your own personal risk for severe disease, the risk in your family or your close contacts for severe disease, and sort of the prevalence at that point, how much COVID there is locally to you in coming up with that decision about the next vaccine dose. So I think we mostly said this, but again, for ages 5 and up, so for most adults, it's going to be 1 dose this fall. If you've never been vaccinated, if you do choose to do Novavax, then 2 doses. If you've never been vaccinated, and for the vast majority of people, because most people have received vaccine in the past, it's going to be 1 dose of Pfizer or Moderna or Novavax, with that extra dose for older adults. And just, if you're interested, there is very close tracking through the Nowcast website. You can go to CDC website and look at the variant tracker and just see what's happening and how quickly sort of these variants are evolving. But this is looking at August to December. And at this point, we're mostly looking at KP311 still with a mix of XEC coming into play. These are all sort of coming from the same lineage, that JN1. And so the thought is that based on data from the companies that made the vaccines, that the vaccine should be active against these strains. I wanted to just briefly mention another agent, which is pemivibart, in case you all are coming into contact with any immunocompromised patients who might be eligible, or just to have an understanding as we're talking about COVID prevention, because I think there's still questions about the role of monoclonal antibodies. We did use monoclonal antibodies for treatment at one point in earlier waves of COVID, but we no longer really have those available. Because they stopped being efficacious against COVID as it evolved. But we do have a newer agent, which is called pemivibart or Pemgarda, and this is actually for prevention. So it's a monoclonal that targets the spike protein, and it's authorized for use as pre-exposure prophylaxis, so prevention, in patients who don't have COVID currently, but are immunocompromised and are therefore thought to potentially have a less robust response to the vaccine. We did go live with offering this at Mount Sinai Health System in August of this year, and we're doing infusions at the Mount Sinai West Infusion Center. And patients are referred there through our ID center in CAM ID on 102nd Street. So patients who are immunocompromised can come for an ID visit and then be linked to infusion if appropriate. Okay, so I wanted to talk about flu as our last bucket. Again, fewer updates with flu, but a couple, so important to think about. And I think most of us are aware of influenza epidemiology, so it does follow more typical winter seasonality with increase in activity usually in October, and that can extend into the spring, but tends to peak between December and March. And flu, unfortunately, is associated with quite a significant number of hospitalizations in the 100 to 600,000 range per year, and deaths in the 5,000 to 30,000 range or so each year. And that risk, as we've seen with everything we've been talking about, is highest in older adults. Again, the sort of list of people who are at higher risk for influenza-related complications, some of these are similar to what we've seen before. The very young, older adults, people with chronic comorbidities related to lung disease or heart disease, immunocompromised, extreme obesity, pregnancy, nursing home residents, all place patients at higher risk for influenza-related complications. And so a couple of notes on this year's vaccine. So all of the vaccines for this year are trivalent. Previously, they were quadrivalent and provide coverage against 2 flu A, and it used to be 2 flu B strains, but we've seen that one of those major flu B strains has essentially disappeared over the past few years, and so is no longer incorporated. And it's a universal recommendation as well for all persons aged greater than 6 months who do not have contraindications to the flu vaccine. That's been a recommendation since 2010. And ideally, it's offered in the fall, actually in the early fall. I know we get questions too every year about timing. Flu vaccine often is available in some places in August and sometimes even as early as July, but that's really not recommended because the vaccine can wane, the efficacy can wane over the course of a season. So really the best time is September to October. I usually get mine in October. The ACIP does recommend a higher dose or adjuvanted vaccine for older adults. That's people greater than 65, and we generally have that available, and it's widely available. There is some data to support improved efficacy in the older age groups with the higher dose vaccine. New this year is that patients who have a history of solid organ transplant, even if they are under 65, 18 to 64, may receive a high dose or adjuvanted flu vaccine. And our EPIC ordering screens, you may have noticed, were updated to include some decision support around this. There's now a question that you're prompted to answer about whether someone has a history of solid organ transplant. If they do, then you're guided towards the higher dose vaccine because of this recommendation. And this is our general flu schematic that infectious disease pharmacists put out each year, showing what vaccines are available here and just compare and contrast with some key information about flu, again, with the standard dose this year, as well as the high dose and adjuvanted vaccines available and recommended for certain groups, including older adults. So just to come back to our case as we round out the discussion. So our patient had received the initial COVID-19 vaccine series, but he had declined further doses. I would not necessarily assume that someone doesn't want a vaccine now because they've declined in the past. I think actually early data from this season is showing that there has been some increased uptake in this fall with COVID-19 vaccine compared to last season. There might be various reasons for that. I think last year the rollout was a bit bumpy. It was the first year that COVID-19 vaccine was distributed outside of the government. And many places were slow to get it in stock, to have it available. I think there's probably an increased understanding that COVID is here to stay and that it's a bit of a seasonal vaccine like flu. So I would offer, and recommend this fall's formulation. I know access is variable. We do offer on-site in our practice, which I think is a huge factor in patients getting the vaccine, but you can also help steer patients towards Vaccine Finder and then a local pharmacy where they can get the vaccine if you don't have it on site. He received the flu vaccine last fall, we said in October. We obviously want to recommend this fall's vaccine. And then he's never been vaccinated against RSV or pneumococcal vaccination or pneumococcal infection, sorry. So again, with a 66-year-old and comorbidities, including chronic lung disease, we can recommend a one-time dose of RSV vaccine and the PCV21 as the pneumococcal vaccine that's now available. And I wasn't going to get into, potential other vaccine discussions here, but there are, of course, this is not all vaccines that this patient would be eligible for. So there are other vaccines to consider discussing, such as Shingrix, Tdap, where we boost generally every 10 years, hepatitis B. So, I find there are many available vaccines for patients, and we've been playing catch up certainly over the past few years, but to sort of triage and decide what's most important at each visit. And just wanted to end with a couple of thoughts. This was from an editorial from Nature this summer. I think one discussion that's been very prominent lately is about vaccine uptake and hesitancy and what we should be doing to increase vaccine uptake. And so I think, the WHO has this schematic about the various drivers of vaccine uptake. And to me, I think some of these are really important to think about. The healthcare worker recommendation is huge, and particularly when patients have a long-term relationship with the healthcare provider, it does make a big difference to recommend something. When patients trust their provider, that goes a long way. And then to me, the other huge one is really access. Again, I think there's a big difference between being in a visit and just saying like, sure, I'll take that vaccine. It's not that much more work for me, versus having to go elsewhere, potentially schedule an appointment, miss more work, figure out register for a pharmacy system, all of that stuff. It creates additional barriers. So to me, the easier we can make it for patients to get vaccines at the point of care, the better. And then a final plug. So the stewardship team, many of you may be aware, but the stewardship team put out this app called First Line in January of this year. It's First Line is a national, actually Canadian company that created this app and has it available, but with institution-specific guidance. So Mount Sinai Health System has our own specific First Line content with common infectious syndromes, as well as dosing guidance and tools like our transmission-based precautions for the hospital, also ambulatory content. And it's available on the desktops here as well as an app. And you can use the QR code to download it if you haven't. We are constantly updating and adding information that folks find helpful or guidance that is useful, both in the inpatient and outpatient setting. And that's it. This is the antibiotic stewardship team, again, a multidisciplinary team with pharmacy and ID, adult and pediatrics. So thank you so much. And we have some time, so can take any questions.